evening, everybody, and welcome all of you to the live program number 134 at Orthopaedic Principles. Today, our guest of honor is Dr. Christopher Gee from Glasgow, United Kingdom. Chris is a consultant trauma and orthopedic surgeon in the west of Scotland. He is an elective practice of soft tissue knee surgery and arthroplasty at the Golden Jubilee National Hospital. His trauma work is at the NHS Lanarkshire, again with a focus on soft tissue and acute knee injuries. And Dr. Christopher has earlier lectured with us, and that was well received. And today is his second lecture with us, and today he's going to enlighten us on osteochondral defects of the knee. Over to you, Chris.
Thank you very much. It's a pleasure to be back again speaking to you all, or this time on another topic close to my heart, which is osteochondral defects of the knee. As you've heard, I'm a consultant up in Scotland in the north of the United Kingdom. And I have a varied practice. The Golden Jubilee National Hospital is a large centre for elective orthopaedics, performing around 4,000 arthroplasty procedures per year. We have many fellows who come to join us, and we're a centre for excellence for arthroplasty with some very good outcomes for our patients. I also work in NHS Lanarkshire, just to the south and east of Glasgow, which is one of the largest health boards in Scotland, where I focus my management on knee injuries and particularly soft tissue knee injuries. In terms of my training, I went to Aberdeen Medical School right up in the north east of Scotland, but did most of my training in the southeast, finishing with trauma and soft tissue knee fellowships at the Rowley Bristow Orthopaedic Centre, Ashford and St Peters, just near Heathrow near London. You can get in contact with me on Twitter or Instagram, Chris G Ortho, or through the Unofficial Guide to Medicine. And I have a website with contact forms as well, chrisgortho.co.uk. And I've recently published a textbook which is aimed at medical students, which you may find helpful for those that are coming through your departments. And the idea is it's 100 practice orthopedic x-rays with some annotated x-rays and reports, which allow the students to get an idea of how to identify different pathology on the x-rays that they see, and give them that confidence, particularly in the trauma meeting. So on to what we're going to talk about today. So it's osteochondral defects of the knee. And in my mind, there's two separate sort of entities within this. There's those patients who have acute traumatic osteochondral injuries, which need management really within a trauma setting, and those patients who are chronic. And while I've said atraumatic, often they aren't atraumatic, but we'll talk about that in due course. And we'll go through the standard things that you need to know in terms of how they present, how you may want to investigate these patients, and some aspects of their management. Before we do that, I think it's worthwhile just a little overview of cartilage. Now, articular cartilage in itself is a topic that you could spend an entire lecture on, but just to understand, there are obviously different layers of the articular cartilage, resisting the different forces that the cartilage is exposed to. So the superficial layers resist shear better than the deep layers, which resist compression. And between those between the deep layer and the bone, there's obviously the tide mark and the subchondral bone. And it's really at this point where the cartilage goes from avascular to vascular. It's important to understand that really articular cartilage is avascular with absolutely no ability for healing. It's also important to understand it's predominantly type 2 collagen in our own articular cartilage, whereas anything or most of what our body creates in terms of trying to heal these osteochondral defects is type 1 collagen. So understanding a little bit about the pathology there is important in terms of how we're then going to manage these patients. And I'll start off with talking about the acute traumatic osteochondral fractures, which I seem to be seeing a huge amount of. There are 2 on the trauma list tomorrow, for example, both young patients, both large fragments sitting in their knee, and both potentially for fixation. You can see an example here, the fragment sitting in the knee joint on the AP radiograph in a skeletally immature patient. And in terms of how they present, well, the mechanism that I see most commonly is a patellar dislocation. You can see the MRI pictures here, which shows a large lipohemarthrosis and rupture of the MPFL. But any twisting or other traumatic injury to the knee could potentially cause an osteochondral fracture. But the two most common mechanisms is obviously patellar dislocation or anterior cruciate ligament injury. It's important to think about the fact that they'll have associated injuries, so MPFL, as I've said, but also ligaments, the menisci, and making sure you don't just focus on the fact they have an osteochondral fracture is important. So when you assess them, obviously you'll look for signs of an effusion and a lipohemarthrosis on X-ray, but you'll want to also assess for instability in terms of AP laxity or medial lateral laxity. It's worth thinking about alignment in terms of their long-term management. If there's significant malalignment, then this may predispose to a poor outcome. And then in terms of patellar dislocation, which is by far and away the most common cause that I see for traumatic osteochondral fractures, think about apprehension test. And then in terms of investigating, you would want to think about CT scan to assess the size of the bony defect and get the best idea of the site. And then MRI can also help with the site and size of the defect. That's particularly useful in terms of understanding any associated injuries, like I said, the ACL, meniscus, or patellofemoral joint. Something that I've noticed is since moving from the southeast of England, where it's pretty sunny, to the west of Scotland, where it's fairly wet and grey, is that there seems to be a much larger number of osteochondral fracture patients presenting following patellar dislocation. And so I suspect that a lot of the patients who are sustaining these injuries are vitamin D deficient. And so I think it's worthwhile organising some vitamin D levels in these patients as well. And then you've got a patient who presents, they've got a large swollen knee, they've had CTs, MRIs that shows a large osteochondral fracture. So you've got to think about, what are the factors that are going to influence whether you're going to decide to fix an osteochondral fracture or whether you may just remove the fragment and allow the patient to mobilize. And so first thing is obviously the site. So if it's a large osteochondral fracture of the patella, such as the young girl I did just at the beginning of the COVID-19 lockdown, she'd managed to knock off her entire medial facet of her patella following a dislocation, and that was worthwhile fixing. Similarly, femoral condyle, weight-bearing portion, it's worthwhile thinking about fixation there in terms of long-term prognosis. Size matters, and for me, anything more than 1 centimeter squared, I would want to at least think about fixing. But understanding the patient as well is important. So younger patients with fewer comorbidities who are more active and sporty and want to return to normal activity, you want to try and do something that's going to preserve their joint for as long as possible. So again, fixation here rather than removal and microfracture and nanofractures is important. Last thing to say is as well is that you want to think about whether it's purely a chondral fragment that's come off. But if you've got a large lipohemarthrosis, it's probably an osteochondral fracture rather than a pure chondral. But obviously, if it's got bone attached to it, it's much more likely to heal. And there are a lot of options in terms of how you can fix these. And I think when you've got lots of options, I think it goes to show that we don't know 100% what the right thing to do is. So that traditionally you would use headless compression screws, as is shown here in the top left of the pictures. These have a variable pitch, so as the screw goes in, it allows for compression across the fracture site, and you can bury these under the cartilage. Problem is that there's a higher rate of backing out of the cartilage thins over time, of causing wear on the articular surface it's touching. So these screws generally need to be removed, and sometimes that can be quite challenging. There are bioabsorbable screws from companies such as Arthrex, and these obviously have the advantage of not being removed, but they're quite large. And so for some of those smaller lesions, there is a concern if you use one of these screws that you may fracture or spin off the lesion as you're screwing it in. For that reason, Arthrex and other companies have produced darts, which you just place in without having to screw them in, and they're much smaller. But having seen these, I feel that they're a little bit too small. And there are nails by a company called ConMed, and I feel that these are a happy medium. between all the options. So you don't have the screwing issue. They come in variable sizes and lengths. They're bioabsorbable, but they're not as flimsy and liable to break as a dart. So I think that's a good balance. And so that's what I do. So the younger the patient, if it's a weight-bearing surface, if it's more than 1 centimeter squared, and this is something I'm going to look to fix. And if it's large enough to fix and is obviously off and floating, then it would be an open procedure for me. I want to freshen the borders. I want to make sure that the cartilage rim is stable. If it's chondral, then I'd consider nanofracture to supplement the potential for healing, make sure I've got through that tide mark. And then I'd use the ConMed smart nails, like I've said, and you can see them here. And it's a really simple technique, particularly if you're doing it open. And I think older patients, less active, not weight bearing, smaller lesions, you can think about nanofracture or microfracture. They're essentially the same thing. It's just I'll talk about the different differences between microfracture and nanofracture later on in the talk. And so that case from that first slide that I showed you, it continued. You can see it's a large defect off his lateral femoral condyle. And in a young, skeletally immature patient, you can't really leave them like this. The MRI scan confirmed a patellar dislocation with this osteochondral fracture off the lateral femoral condyle, as you again can see here. And for me, I think it's important to scope the knee first, in part to understand the pathology, but for other reasons too. So MRI, we know, is not 100% accurate, and I'd want to make sure that I'd seen both menisci clearly, particularly the roots, and also had a good chance to assess the ligaments for stability. Also, as was the case in this patient, is that the osteochondral fragment was actually tucked right back behind the lateral femoral condyle, and with an open procedure might have been difficult to identify. Scoping it first and insufflating the joint with fluid allowed me to identify the fragment, although it took some time, and then able to bring it forward before I opened up the knee and removed it before fixing it back on. And that's what I did. So I fixed it initially with a K-wire, made sure the margins matched up, having freshened them up, and then fixed it with ConMed nails. And I know that for lesions that are in situ and smaller lesions, some people would attempt an arthroscopic approach. But for me, I think the key is to get it anatomically reduced. And to do that, you need to see it and see it well. And for that reason, I think an open approach is reasonable for these sorts of size lesions. And in terms of healing, you can see a great post-op MRI here. You can see the nails. You've got different length selections that you can use so you can avoid the growth plate. And you can see here that these heal, particularly in these skeletally immature patients, fantastically well. And this was 6 months post-op. When I was basically back to normal function, not understanding what the fuss was about at the age of 13, as you can imagine. So I think, in summary, you need to have a low threshold to investigate the knee injury with a large effusion, and do it acutely, because I've certainly seen quite a few cases of osteochondral fractures that have been missed or put down as a minor sprain of the knee, and very recently picked up an osteochondral fracture where there's nothing on the x-ray to see, but because of the large effusion, organized and a lipohemarthrosis, organized an MRI scan which showed an osteochondral fracture that will be fixed tomorrow. If they're younger, more active, bigger lesions, obviously you want to think about fixing those, and it's important to assess for other underlying pathology. And I think if they've got, other underlying pathology, whether it be ACL or patellofemoral, you need to treat these fractures first, get them moving, get it healed, and then do a staged procedure in terms of whether you need to do anything further from their patellofemoral joint stability or their ACL. But certainly that's an area that's open to discussion. So that's how I manage acute osteochondral fractures. And I'd encourage you all to try and investigate and look for these and fix them as much as possible, because once they become chronic and fixing them back on is not really possible, and it's likely to fail, then you've got this situation where you've got chronic osteochondral defects. You need to think about the whole patient. You need to assess the whole limb. You need to think about whether the knee is stable, what their alignment is. what's going on in the joint above and below, as you can see in this example here of a gentleman with an osteochondral defect on the medial femoral condyle. It's certainly a lot more to it than just the cartilage problem here. He's got significant varus in part as a result of pathology in his hip, and potentially needs more than just a cartilage operation. So I think for all these patients, when you're assessing them, you need to think about long leg alignment X-rays and MRI scanning. In terms of how they present, well, like I said, chronic OCDs are often seen as atraumatic, but actually quite often there is a history of trauma. They may not remember it, or it may have been a while ago, or it may have been felt to be a minor trauma. But the patients we see, many of these with these previous trauma, they don't really go to see the doctor, or they went to A&E and they're told they just sprained their knee, and they're sent away and they struggle for many years. And it's only when they eventually come back and see an orthopedic surgeon that the scale of the problem is identified. And at that point, you've got a patient with a chronic osteochondral defect, often young, often wanting to get back to work. Generally, they end up being manual laborers as well. So, they're wanting to work on their feet all day, and it can be very difficult to manage. In older patients, you may see, following minor trauma, medial meniscal root tears leading to spontaneous osteonecrosis of the knee. I talked about this case in my last talk, but it's a good example of what can happen following a minor trauma to the cartilage. And in younger patients, you think about osteochondritis dissecans if it is an insidious onset. And then in terms of the symptoms that they have, it's as you can imagine, so they'll have pain and they'll have instability from either fragments floating around in their knee or from catching from loose cartilage rims from the lesion. And the pain often tends to be focal, either on the medial lateral femoral condyle or patellofemoral joint, just depending really on where the lesion is. And as you can see, for these patients who have chronic osteochondral defects, there's a lot of options. And I think the fact that there are a lot of options tells me one thing, which is that there's no one definite thing that's going to be able to solve the problem for all these patients. And we'll go through all the evidence and some of the evidence for all these different procedures. But what will be clear throughout is that the outcomes for all of these are not perfect. And so having a good understanding of your armamentarium and what's available to you is really important. So first thing to talk about is radiofrequency chondroplasty, which is good for focal defects, perhaps grade 2 or 3, where you've got a rim of cartilage that you can stabilize with your radiofrequency probe. And I was very skeptical when I came across this procedure or this device. It's an expensive bit of kit to open for every case, and seemed hard to believe it would make a huge difference to patients and their outcomes. Just what on the face of it, as a innocent trainee, seemed to be burning a bit of cartilage. So I did some digging around, and there's actually UK what we call NICE guidelines on this procedure. And what these really show is there's a huge amount of evidence that shows that if you compare this to mechanical debridement, the patients do much, much better. So you can see here one study just as an example from the NICE guidelines. You can see the code there if you want to go and look them up yourself. That the patients have much better pain, much better overall symptoms, better return to activities of daily living, return to sport, overall knee-related quality of life, and getting back to a normalized KOOS score. And you can see in terms of this study, this is a 4-year follow-up, so it's just a short-term benefit either. So you get the right patient for this procedure. You can give them, mid-term good follow-up in comparison to if you just shaved away the rim of the cartilage. So I think radiofrequency chondroplasty certainly has its role in managing discrete chondral defects of the knee, and it's something to bear in mind. So moving on to microfracture. Well, microfracture traditionally is using picks to make holes in the cartilage. The idea is that you perforate down through that tide mark, so you get bleeding into the defects that you've created. This will encourage fibrocartilage formation. There's different ways that you can do this. So you can do the traditional microfracture with a pick, but there's also micro drilling and nanofracture. The idea is that you're just trying to do something to encourage as much bleeding out of the holes that you're creating, to encourage as much, like I said, fibrocartilage to form. But there are problems with it in terms of the fibrocartilage that is forming is not as mechanically stable and is not natural cartilage. And often when you re-image or re-scope these, you don't get a nice smooth layer of cartilage over the defect, and you get an irregular attempt at healing. Obviously, you need to think about pre-op imaging and scope the rest of the knee. And like I said, always think about stability, alignment, and the whole of the patient. But in terms of the technique itself, you want to be able to correct the base and the edges, adding RF chondroplasty to those to the rim as necessary. And this is the kind of pictures that you'll get. So you can see here, top left, a nice example of curettage, and then there's a traditional microfracture pick forming a large number of holes into quite a large defect. But there are some concerns, like I said, about the traditional microfracture picks in terms of whether they really perforate deep enough to get good fibrocartilage formation. So as I showed there's on the previous slide, there's microfracture drilling, and there's also something called nanofracture. The idea is that you make more holes, smaller holes, but deeper holes, and you get less impaction of the bone and more channels created, which will encourage better bleeding into the defect and better fibrocartilage formation. But the fact is that while microfracture is probably one of the most common procedures that we perform for these patients, the evidence is really lacking in terms of the benefit that it provides. So it does provide some short-term benefit for patients. And if you look at the sort of first couple of years following microfracture, there's some evidence that patients do get an improvement in their symptoms. It doesn't appear that this is a return to normality for the patient, but it's something nonetheless. And perhaps smaller lesions, this is good enough. But more and more studies are coming out looking at the sort of more long-term results of microfracture, really showing that there's quite a high incidence of further procedures in the future, albeit, whether that be further cartilage surgery or even arthroplasty. And after a few years, it's clear that the function in the patient does deteriorate. And so while microfracture has its place, I think it's important to understand that whilst it's simple to do and it's something that we all do a lot of, actually the evidence behind it isn't as wonderful as we'd all like to hope it is. And for that reason, we need to think of some alternative solutions for managing these cartilage defects, because if we can preserve our patients' joints and keep them fitter and active for longer, then obviously this will have a big impact, not just in terms of need for arthroplasty in the future and the costs associated with that, but if our patients are being active and healthy and keep living a healthy lifestyle, then their overall health from a public health point of view will be improved. So I think being aggressive in younger patients with osteochondral defects in terms of your surgical management is important in terms of improving their long-term outcomes. And so I've become quite interested in a procedure called AMIC, which is autologous matrix-induced chondrogenesis. It's not really autologous in that you're not implanting new cells, but the idea is that you put down a membrane on top of your nanofracture that will encourage that fibrocartilage to form in the defect in a more organized fashion. And if you go on the website for ChondroGuide, you can see that they'll say they've got stable clinical results at 10 years following the surgery, which is obviously really helpful, especially say you've got a 40-year-old gentleman, you want to get them as old as possible before closer to retirement, before you start thinking about joint replacement surgery. Then this is a good operation for bridging that gap. And if you've got longer term outcomes that are better than microfracture, then that's great. And so this is the kind of case where you might consider it. This was a gentleman, like I said, in his 40s. You can see normal cartilage and then an area of complete cartilage loss following a trauma that presented late. And you can see that fiber cartilage trying to form in a really disorganized fashion, really failing to do anything. This gentleman had significant ongoing symptoms. And so for these, you can see you can do microfracture and get good bleeding. But the concern is obviously this isn't going to be enough in the long term. And I want to get this 40-year-old gentleman out to 50, 60 years before having his arthroplasty, if at all. And so you get this chondral, this sheet of bilayered sheet of matrix that you fit to the defect, and then you don't even need to stitch it in. You can glue it down with a fibrin glue, and this will potentially encourage better cartilage formation, a smoother defect, and preserve that joint for longer. Now, if you look at the NICE guidelines on AMIC, where I would say they're suggesting that the jury is out, you can see, looking at a study between microfracture and AMIC, that the early results at 2 years, there was no statistical difference in the groups. And this is from 2013. But now there are studies out to 2017 which show that, sorry about this, that show that in an RCT between microfracture and AMIC, that you get this much better sustained benefit for the patients. And for this reason, the UK and the National Institute for Health Research, the NIHR, just before COVID, were planning on funding to the tune of £1.5 million, a multi-centre randomised controlled trial comparing chondral to microfracture. And it may be that this is better for the long term for these mid-sized lesions, but I guess we'll need to wait and see until we get the results of this study. Other options in terms of what you can do for mid-sized lesions, well, there's Mosaicplasty and OATS, which stands for Osteochondral, sorry, words are gone. Osteochondral autograft taken from another part, a non-weight-bearing part of the femoral condyle. And the difference between Mosaicplasty and OATS is, with OATS you take a single large plug, and with Mosaicplasty you take multiple small plugs. Whilst you're taking multiple small plugs, generally speaking, Mosaicplasty is reserved for larger defects where you need multiple small plugs, whereas OATS is used for smaller defects. And you can see a nice example here of what Mosaicplasty is. It's not a minor procedure to have done, but for large defects could be quite effective, and certainly get nice intraoperative pictures. And then in terms of the results, well, again, the results are certainly limited. There's more research required. The best sort of papers I could find said that there was variation in the outcomes following these surgeries. But younger patients with smaller defects, perhaps less than 3 centimeters squared, tended to have a better outcome. But I guess it's a good thing that the younger patients are the ones having the better outcome, because those are the ones we want to try and preserve their joint for as long as possible. Another alternative is Allograft, which has some advantages. So there's no donor site morbidity. And however, there are some challenges in this. So you really need fresh graft, because all the techniques to preserve the graft kill all the chondrocytes. And you also need to match it to the patient's architecture. So it makes it quite difficult just from a logistical point of view. You need to investigate the patient, and then you need to then you need to find the graft, the donor, and then you need to try and get the patient into theatre with a short period of time following the identification of that donor graft, and get them into theatre and done as quickly as possible. In the NHS, that's very difficult to do, as you could imagine. You then need to core out a dowel of bone and cartilage, which will match the socket that you've also called out. And you need to make sure you're marking the top and to make sure you match it up properly as you put it in. And it's a press fit, so there's no need for any fixation. Once it's in, it should be fine. And there's not a huge amount of evidence really in terms of allograft. Last thing to talk about really is AC and Maci. And so this is autologous chondrocyte implantation or matrix. Matrix associated chondrocyte implantation. And basically, this is a two-stage procedure. So you take some cells from the patient, you culture them in the lab, and then you've got two options. So with AC, you basically place the cells on the defect and you attach a periosteal patch over the top of this. The other option is to actually grow the cells in the lab on a matrix, which is Maci. And while some of the early techniques for this didn't have the best outcomes, the latest techniques seem to be working quite well, but it is very expensive, running into thousands of pounds in the UK at least. It's a two-stage procedure, so the patient obviously needs multiple operations, and there are a few labs that are equipped to perform the procedure. That being said, the NICE guidelines that have looked at ACI have shown that there are improvements in patients at least out to 5 years, and while there's no long-term results to say, it's definitely worthwhile considering. It is supported by NICE as something to consider, particularly for larger defects, where the other options have been shown to be not as effective. And so that gives me a way of creating a flow chart to think about how I would manage these patients. So if you have a patient with an osteochondral lesion and it's acute, then the first thing I would think about would be for those larger lesions and a weight-bearing surface, particularly in younger patients, then fixation. And for me, that's with a chondral dart. For smaller lesions and a non-weight-bearing surface, particularly older patients, then I might think about resecting the lesion, and then microfracture, whether that be nanofracture, whichever way of performing your microfracture type technique you want to do. For the chronic patients, the smaller defects, less than 2 centimeters squared, I'd perform a mixture of radiofrequency chondroplasty and microfracture. And those mid-sized defects, for me, it's a mixture of nanofracture with AMIC, but there are obviously other options available. And then for the larger defects, I would be wanting to proceed with ACI or Maci. It's all well and good having this idea of what you're going to do with the lesion itself, but please remember, when you're managing these patients, you need to think about alignment. So whether an osteotomy would be indicated, the meniscus, has it been resected? Is there a need for, if the whole meniscus has been resected, is there a need for meniscal transplant? And in stability, do you need to consider, ACL reconstruction, for example, at the same time? Because it's all well and good performing these procedures, but if you've got an unstable, malaligned knee without a meniscus, then they will not work in isolation. There are some other options which I haven't really talked about, but there's a big vogue at the moment for different injectables, whether that be PRP or something called lipogems. And I think the evidence is really out for these. So there's not a huge amount of evidence to really say that they work well. For patients who are symptomatic, not wanting surgery, I may consider injecting them with local anesthetic and steroid as a symptomatic thing, but I don't think it's going to really give them any long-term benefit. Offloader braces similarly are useful in terms of providing temporary symptomatic relief for some patients. They're not tolerated by everybody, but for some people they seem to work really well. And they also have a use in the post-operative period. So if you want to protect your cartilage procedure, then an offloader brace is perhaps a good way of taking some of the forces off that knee while the patient mobilizes. You do need to think about alignment and osteotomy in these patients. I think that's an imperative part of joint preservation surgery. There are other devices out there, such as the HemiCap, which I have not seen used, but have seen removed, and I don't think these are particularly of much use. I think if you're thinking about placing some form of metal in the knee, then really you're looking at arthroplasty, whether that be unicompartmental or total knee arthroplasty. So that's a run through some of the evidence and my thoughts on osteochondral lesions in the knee. I think it's fair to say that the management of these lesions remains controversial. There's definitely no perfect treatment for all lesions. And like I said, having an understanding of all the different options available to you, particularly within your local hospital, what's on the shelf, and understanding how you can use those to your advantage is important. I think the long-term outcomes that we've got suggest a need for improved treatments, and perhaps with time, as ACI becomes more cost-effective, it may be that this is something that we can do in greater volume. But certainly, if you're looking for an area to research in your own practice, then I think the management of these osteochondral lesions is somewhere where research is definitely lacking, and I'd encourage you to investigate further. I'll leave up my flowchart, and thank you very much for the time. Apologies for a couple of interruptions there that affected my train of thought, but thank you very much.
Thank you, Chris, for yet another fantastic lecture, and this has been a very useful lecture for everyone. A couple of quick questions. I really like the slide where you put the comparison between microfracture and the nanofracture. Mm-hmm. My question is, do we really need subchondral bleeding into the defect? Because that is where the pluripotent stem cells are, right? And that is not happening in a microfracture, isn't it?
No, so if you look, there's some nice, albeit, it is in the literature from the company that sell nanofracture, but show that really with that pick, you're impacting that subchondral bone. So all you're doing is making it harder for the stem cells to come out through that channel. Whereas with a drill or with nanofracture, you're not doing that, because you're allowing that channel to remain open because there's less impaction. When you think about the shape of your microfracture picks, there's no way they're long enough to really make a big difference. They skiv off, and I don't really think they do the job. And it may be that that's part of the reason why microfracture, well, in theory, should work, doesn't work as well as we'd hope.
So I think that the best thing, I have had a lot of scenarios where I have encountered defects, and what I like to do is I wanted to see the bleeding. So, but when I looked at the data, a lot of people do microfracture without going deep into and really cause the bleeding. So that is why that particular slide of yours, nanofracture, which clearly says that you need the bleeding there, isn't it?
Yeah, absolutely. Yeah, and I think, like you say, if I go back, hang on, I'll go back to. It's from the AMIC slide, but you can see here that with nanofracture you get definite bleeding through the defects, so through the channels. So I think that's like you say, really important for long-term outcomes for these patients. So it's definitely a
the other thing is regarding the other question is regarding the AMIC procedure, matrix-induced chondrogenesis. The scaffold that you use is collagen, right?
Yeah, bilayered collagen from it's porcine.
Porcine collagen. The other question with respect to this is, do you think if you add BMAC, bone marrow aspirate concentrate, to this, it will provide a better cartilage regeneration?
So I guess BMAC and PRP and lipogems, all these injectables or things that you can add to try and encourage new tissue formation. For me, I can't imagine that what you would be putting in there would be more than what your body can put in there through those channels, if that makes sense. So, surely there's enough stem cells if you get deep enough with your channels that will be enough. And I kind of have the same thought process with non-unions and the management of them in terms of, if you stimulate bleeding at the fracture site, then that bleeding and the bone marrow content is surely enough from a biological point of view. So I don't really wouldn't routinely add anything to it.
And out of the three substances that you mentioned, for example, BMAC, PRP, or the lipogen, I think the biggest source of stem cell is BMAC, isn't it? Compared to the lipogen, which is nothing but mesenchymal-derived adipose tissue.
Yeah, it's just spun down fat cells, but saying that there's more stem cells in fat than any other human tissue is what they'd say. I'm quite skeptical about it. I think PRP it's shown, some not that great papers out there that show some benefit for some patients. I think if a patient came to me asking PRP, I might try and organize it for them, but beyond that, I wouldn't consider injectables. So
the other one is using hyaluronic acid along with these procedures.
No, it's the same thing. My understanding is that the evidence isn't really there to support the use of hyaluronic acid. There was one study that showed that hyaluronic acid had a benefit in some arthritic patients, but it was when they were using an injectable that had hyaluronic acid and steroid in it. So it was probably the steroid that was the benefit rather than the HA.
And Chris, before we wind up, one last question. See, I just looked at the data of AMIC, and there's a recent systematic review that is published in the American Journal of Sports Medicine by Gao et al., which says that the evidence for AMIC is not very good. I mean, it's just in par with microfracture or even lesser. What do you think of
that? I think it's certainly an area that needs explored further. I think that it's too soon to say it's superior. Maybe I'm just treating myself. It's a big defect. It feels like microfractures not enough. I know the evidence isn't great for microfracture. I want to do something more for those patients. I think the fact that the NICE are beginning to or want there to be a large study looking at it, and I want to be involved in that study, makes me think that they either think it does or doesn't work, and they want to prove definitively one way or the other. I think the jury's still out, is the honest truth. But I think it may be a beneficial solution for those in between patients, but time will tell. Maybe I'm just young and foolhardy and excited doing new things.
Thank you, Chris. I think that's all the questions that we have for the session. Thank you for yet another fantastic session. Everyone has learned a lot from all your lectures. I'm sure it's going to benefit a lot of people all over. And we really look forward for another one, maybe not immediately, but when you have time later on.
Yeah, no worries. A pleasure again.
Thank you so much.
No worries. Take care. Bye-bye.